Okay, it looks like we are going live. So my name is Tim Wiegand. Welcome to the October Addiction Toxicology Case Conference. The theme is Not Your Common Withdrawal Syndromes. This is brought to you by the American College of Medical Toxicology and the American Society of Addiction Medicine, who have joined to collaborate on this monthly webinar series. For past sessions and FAQs on several of these, which were supported through a grant from the Opioid Response Network. We've got links at acmt.net and a number of excellent FAQs, as well as past recorded sessions. I'm Tim Wiegand, the Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center. And Dr. Gloria Bashevitz is my co-moderator. She's Medical Director of Strong Recovery and Professor of Clinical Psychiatry in the Department of Psychiatry at the University of Rochester Medical Center. We have some excellent panelists today. My colleague, Dr. Tim Carnes, Medical Director of Pine Tree Recovery Center, Guardian Recovery Network, Portland, Maine, and Dr. Joseph Carpenter, Assistant Professor, Department of Emergency Medicine at Emory University School of Medicine in Atlanta, Georgia, Dr. Zachary Illig, Medical Toxicology Fellow in the Department of Emergency Medicine at Emory University School of Medicine, Atlanta, Georgia, Fellow in the Tox Fellowship, and Dr. Elena Steck, Associate Professor in the Department of Emergency Medicine, Emory University. She's also Medical Director of the Grady Medication Assisted Opiate Treatment Clinic and Assistant Medical Director of the Georgia Poison Center, Atlanta, Georgia. I want to announce the call for abstracts. The annual 2022 ACMT scientific meeting is still open. The meeting is March 11th to 13th, San Antonio, Texas. Abstract submission deadline is through Monday, November 15th. The ASAM's abstract submission deadline closes today, October 1st. So if you're hoping to submit an abstract for ASAM, you just have today, and ACMT you still have until November 15th. None of our speakers have any conflicts of interest to disclose regarding our presentation, and I will jump right in. Case one is looking for a withdrawal protocol, and this involves a 23-year-old male with use of 7 grams a day of Phenibut who has anxiety, tremors, and sweats with any attempts to taper. And he's looking for a withdrawal protocol at a medically supervised detoxification level care for about 7 to 10 days. He's got a limited amount of time he can try and get off of the Phenibut. So this 23-year-old gentleman calls a local detox and asks if he can be admitted to help with Phenibut dependence. He has a history of opiate use disorder, opioid use disorder, with recent buprenorphine prescriptions for 12 milligrams a day, 2 twice a day, and 8 midday. He denies other drug use, except he is prescribed levetiracetam, Keppra, which he didn't bring in. He reports having a seizure in the past years ago, vague about what it's about, and trying to taper the Phenibut even a little bit at home. His tremors, nausea, diaphoresis, insomnia, and anxiety. When the patient arrives at the detox, they're brought in for an intake assessment, which includes a nursing evaluation, medication review, a urine screen, and a check of the prescription monitoring program, a PMP, which shows current Clonazepam, which wasn't brought in and wasn't prescribed initially, and then the buprenorphine, which ended about 7 days prior. So he's been out of the buprenorphine prescription. Patient reports last use of Phenibut earlier that day, about 6 hours prior to arrival, about 4 grams by mouth, and comments that it burns if I sniff it. He also reports that he should be taking lurasidone, sumatriptan, ondansetron, and trazodone, but did not bring these meds in, or the Clonazepam, which is about in the middle of a prescription. And you can see the prescription monitoring program with the buprenorphine prescriptions. And the Clonazepam is at 0.5 milligram twice daily. He's been on that for a little over 2.5 months. Past history includes seizures, and history elaborates a little bit. He describes after using Kratom, or the Kratom withdrawal, but he's not currently using Kratom, and anxiety, and then bipolar disorder and migraine. A urine drug screen is done on site, and the point of care testing reveals ethylglucuronide, buprenorphine, and THC. It is negative for opiates, opioids, fentanyl, methadone, methamphetamine, amphetamine, MDMA, tramadol, benzodiazepines, cocaine, and ethanol. And of note, Clonazepam would not be picked up by that benzodiazepine screen, so I'm not sure if he's been taking the Clonazepam, supposedly had. Breathalyzer, negative. and again, urine screen positive for ethyl glucuronide, buprenorphine, THC. My question to the panelists is, what is Phenibut? Have you seen use, dependence, and withdrawal in your practice? And then, after just simply what is it? Have you seen it? What would you do for detoxification? How would you monitor for symptoms? And then what are other plans regarding this patient's medications overall? So I'll start with Dr. Carnes. Have you seen Phenibut, and what is your experience?
Right. So I'm up in Portland, Maine. We have seen Phenibut. It is in the United States, primarily a supplement. It's used overseas, for various medical conditions, but primarily anxiety. I'd classify it as a sedative, though it does have some sort of low dose, has some stimulant properties, improved focus and things like that. But so essentially it's a GABA analog, and we have seen some Phenibut. I'm at a withdrawal management facility in Portland, and we've had, I think in the last 3 years, we've had 2 cases, and fairly significant dependence. I think the recommended daily maximum dose is 2 grams. I think this gentleman was using 7 grams, if I remember correctly. So definitely would expect some withdrawal and difficulty cutting back on his use. What I have used in the past in terms of withdrawal, I am in a sort of medically monitored detox setting, so I'm fortunate enough to be able to use phenobarbital, and I essentially treat it like benzodiazepine dependence, and I've used a protocol where essentially loading with phenobarbital over a 3 to 4 day period, 130 milligrams every 4 hours, the next day every 6 hours, the next day every 8 hours, sometimes every 12 hours, and then we'll, like I do with benzodiazepines, valproic acid in a dose of 500 twice a day for some of the neuropsychiatric symptoms that sort of residual after coming off of benzodiazepines, and the same with Phenibut. My experience is that worked really well for Phenibut, as it does for benzodiazepines. And there's certainly some other options, especially if you weren't in an inpatient medical setting, but that's been my experience, is primarily using phenobarbital. In terms of,
we can get to the next question actually at the end of that. Okay. There's a lot to hear, so we'll come back to the other meds, but yeah, that protocol sounds familiar. I like that protocol, but it depends really if you set and setting. So that's great. Dr. Steck, you have we're talking about this, your experience with Phenibut.
Yeah, so we're down in Atlanta, and we haven't seen Phenibut down here in a couple of years, but we did have a handful of cases a little while back, and we were able to manage those folks quite successfully by getting them on pretty hefty doses of baclofen to begin, and then tapering the baclofen over a period of time, just stabilizing them as an inpatient over the first 24 to 48 hours, and then discharging them with supervised follow-up for an outpatient taper. And that worked really well for both of those patients.
And how do you monitor for symptoms as you detox? You're using CEWA?
Yeah, we use a version of the like hospital-specific version of the CEWA protocol down here, and given its similarity to the other sedative hypnotics in terms of its withdrawal syndrome, it makes sense, or it made sense at the time, for us to monitor with that hospital-specific CEWA protocol, and kind of adjust the doses based on the severity of symptoms.
Good. Dr. Illig, have you seen Phenibut in fellowship or residency? Do you have any other comments and mechanism? thoughts?
Yeah, so I did my training in Detroit, and we actually saw kind of a handful of cases as a resident in Detroit, but not so much on kind of the addiction medicine side. And admittedly, as I've started my fellowship here in Atlanta, I have not seen a case yet. Kind of like Dr. Steck alluded to, it sounds like there was maybe a rash of cases a couple years back, but not something that we commonly encounter, at least here in this community. So have yet to see one through the course of my fellowship training. We do see a fair amount of GHB withdrawal, which has been treated similarly with the baclofen taper, but to date, no Phenibut.
Thank you. Dr. Carpenter, do you have any other comments?
Unfortunately, I'm not sure I have a whole lot to add on top of my Atlanta colleagues. I did my residency out in Los Angeles, where I always joke that everybody out in California was using stimulants and other uppers. Primarily what I saw at the time was synthetic caffeinones. So no Phenibut that I've experienced personally.
Well, that's interesting. It seems to be somewhat regional variation in trends, but I've at least noticed an increase. Some data later on to show that shows a little bit of decline in 2019, but I think with COVID, people started to order things online again a little bit more. So it'll be interesting to see what the current trends are. Dr. Bashevitz, in your practice, have you seen Phenibut? And then there looks like there's a couple of comments in the chat. Anything that you want to bring up?
I've actually not seen Phenibut here because I'm in an outpatient practice. So normally people come to our outpatient program when they graduate to something else, and often they don't consider the Phenibut to be anything other than a recreational thing that they do for a while. So no. And I think the questions in the chat have been answered by other people in the chat.
Great. Okay. Thank you. Well, let's go back to then Dr. Carnes. This patient, some other medications, buprenorphine, clonazepam. At least to start, would it influence, what your protocol? How would you address these other medications?
Sure. So the clonazepam, not something I think this would be a great opportunity to recommend that he get off of clonazepam in terms of his sort of opiate use disorder history, and he's on buprenorphine, so definitely increases his risks of complications, oversedation, overdose risk. And that combined with some of the other medications he's on, I don't have the list right in front of lurasidone, trazodone, sumatriptan, and ondansetron, I believe.
Ondansetron, yeah.
So what strikes me with that list, a lot of CNS active medications, polypharmacy, drug-drug interactions, and a concern, with those four at least was serotonin syndrome. So something that I'd have in the back of my mind. But in terms of clonazepam, the phenobarbital protocol would cover that, which is another reason that I would use the phenobarb. In terms of buprenorphine, the regimen itself that he's on, I think it's open to interpretation and it's a little complicated. I would recommend once daily dosing, if at a maximum twice daily dosing, unless there's a really strong indication, which I didn't get from the history of splitting the doses for chronic pain. And then, in terms of the interactions between, the one thing I would say with phenobarbital is we often need to do drug-drug interaction checks, with a lot of different medications, and lurasidone, not something I see a lot of, but does come up as sort of a big X, red X, but the primary reason for that is that phenobarbital induces metabolism and can lower the levels of lurasidone. So not something, the other thing I would get an idea of how, from pharmacy records, how often he's taking these medications, whether it's something that, does he have true diagnosed bipolar disorder? Was this diagnosed in the setting of drug and substance use? But in general, I think getting him off of clonazepam, keeping him on buprenorphine in a simplified regimen, and seeing if you could decrease the risk of drug-drug interactions with some of those other medications he's on. So.
Yeah, no, that's good. And I think the key here was getting consent right away and then contacting the prescriber for clonazepam so they're on board. And my strategy is usually then to, work with the patient here for sedative dependence, and clonazepam is a sedative, and going to be an opportunity to detox not just from the Phenibut but the clonazepam, and look for alternative agents. And this patient actually had been off of buprenorphine supposedly for 7 days, was positive in the urine, but initially wanted to stay off everything. So the dose, I believe, was the 2 BID related to migraine, but it wasn't clear from the prescriber why. It was an 8, and then it was a 2, then 8, and 2. So it seems, I agree, that was a little bit odd. I could probably have switched to a BID. Any other thoughts on the medications, Dr. Steck?
I agree with everything that Dr. Carnes said. It's a good opportunity to reevaluate the need for his clonazepam, and then attention to the drug-drug interactions. But, maybe the one other thing that I would add is, some gabapentin to the regimen if he's having some breakthrough withdrawal symptoms from the Phenibut, or if you're, like Dr. Bashevitz was saying, if you're in a place that is more outpatient structured and isn't going to be using phenobarb, I think that's another adjunct that you can toss into the mix.
Yeah, that's a good thought. This setting, at least in New York State, was not allowing phenobarbital. It's an ongoing dialogue about whether it may be allowed via protocol, but at least for the time being, it's not allowed in this specific setting. So we did look for some other options, but that, I think, my go-to protocol would have been very similar to Dr. Carnes, if not identical, and some adjunctive quantity maybe. And then discussing restarting the buprenorphine, maybe in the context as to why it wasn't continued. Anything else to add that we haven't covered, Dr. Carpenter?
I mean, I would love to know from this patient, really, are they taking the clonazepam? Do we need to worry about them developing withdrawal syndrome from it? If you're in a setting where you can give phenobarbital on the taper, as Dr. Carnes described, great. But if we're going to lean heavily on baclofen and this patient is taking clonazepam on a daily basis, my question would be, are we going to have to add some form of GABA A active agent to treat the clonazepam withdrawal, be it a benzodiazepine or something else, whatever's allowable at our facility? So is the question would be, can we give the phenobarbital in that protocol that you've discussed, or are we going to get into a situation where we're going to be relying on multiple agents? I'd love to have the clonazepam off, as the other panelists have said. And then in terms of the buprenorphine, I'd probably just see if we could continue it where it was. I'm generally a fan of having as few wheels in motion as possible, so that we're trying to keep things nice and simple. And know if we're seeing any effects that it's coming from that one wheel that we're moving, rather than having possible interactions between multiple tapers at once.
Yeah, that's a great point.
Yeah.
Dr. Bashevitz, do you have anything in the chat? We've had a couple. Go ahead. Do you have something else, Dr. Carpenter?
No, nothing. Oh yeah, here's a question in the chat. The medically supervised withdrawal is one thing, but helping the person stay off the drug is another, especially in the view of polypharmacy. How can we help make that happen? Are any meds useful for this long term? That's always the $64,000 question.
Yeah, I think that's a great question. And one of the reasons I like to add at the end valproic acid, I think there needs to be further study. Talk a little bit more about the use of valproic acid. I use it for kind of the protracted. There's an acute withdrawal and then kind of some protracted subacute symptoms that I think, whether it's alcohol, sedatives, combination of the two, individuals may have anxiety, insomnia, dysphoria. That's not really the acute withdrawal, but valproic acid has a couple mechanisms, but raises GABA levels and really is not a substance individuals misuse or don't seem to take extra of. And I've had a lot of success with people feel like mood stability with that, and that may be the mood stabilization effect, but it also may be that they, have some higher levels of GABA, and that's counteracting some of the craving as well. I'd be interested in getting other thoughts on that. But sedative use disorder is very challenging. There's a lot of sedatives out there, in addition to what people really don't consider sedatives, and then Phenibut. We've got gabapentin. It flies under the radar, so people really can, have access and return to use very quickly if we don't support them, in the right way. And that would include cognitive behavioral therapy, appropriate mood stabilization, anti-anxiety meds, maybe trials of other agents. But I think the first thing is getting through the withdrawal, and then that's really only the beginning. Any other comments? Otherwise, I'll move forward with that.
And another comment here is, of course, that there may be some underlying anxiety or PTSD, which you may see later on. But yeah, let's move on to the next one.
Yeah, so, and we had in this, if I recall, some alcohol was in here and screen THC. So there's some others, so certainly getting a thorough substance history. A little bit, just some background on Phenibut. I want to comment a little bit. It developed in Soviet Union in the 1960s for anxiety and insomnia. It's still used in Russia, Ukraine, Belarus, Kazakhstan, and Latvia. It's used to treat other conditions, most notably alcohol use disorder and alcohol withdrawal, and some other uses: asthenia, depression, alcohol withdrawal, PTSD, stuttering, tics, vestibular disorders, Meniere's disease, dizziness, motion sickness. It's also used in the U.S. as a smart drug or nootropic. That's what it's often advertised for, or to boost your social, or to treat your social anxiety, just help with social butterfly. Some of the advertisements that I've seen for this really are very attractive. I can see why people are interested in this. In the United States and Europe, it's sold as a supplement. It falls under supplements. It's controlled in a few countries, controlled in Australia, and a ban is on it in Hungary, Lithuania, and Italy. Most often it's consumed orally. So there have been IV and intranasal rectal use, although it's very irritating to the mucosa, so most individuals don't use it, particularly nasally or rectally. Brand name, a variety of different brand names and reference on Phenibut. This is a typical advertisement poster. Phenibut, your ultimate guide to unlocking your social side and more with this powerful pill. It's available as a powder, a pill, and tincture. It's recommended the doses start at 250 twice a day to 3 times a day, or up to 750 BID. It is not FDA regulated, and recommendations are that it should not exceed 1 gram per dose or 2 grams a day. This patient was taking 7 grams in a day. It has a calming effect at low doses, in particular, no depressive effects, and there's increased focus, at least per report, and described in a lot of the user sites and advertisements, but without the edginess of a stimulant. Again, sold as a nootropic, so cognitive enhancer, increase your wakefulness, your concentration, and then anti-anxiety without the sedation. This is a slide that shows the structure of GABA, gamma-aminobutyric acid, up in the left, top left, and then GABA analogs, which Phenibut is a GABA analog, or you could classically call it the gabapentinoid, the GABA analog. And right under GABA, you see the Phenibut. So substitution on that middle carbon, you have GHB, which is gamma hydroxybutyrate, baclofen, GABA analog, pregabalin, and gabapentin on the bottom, and then tolobut, another analog as well. There's differences in pharmacology despite these all being GABA analogs. Baclofen, a GABA B agonist, works at presynaptic receptor, causes GABA to be released, and then gabapentin and pregabalin work at the alpha to delta subunit of the voltage-dependent calcium channels. So this is a indirectly GABAergic. It enhances GABA transmission. It's not different than GABA B, but clinically it's somewhat similar. There's dramatic differences in potencies, duration of action, and other effects with these. So they are not all the same, but structurally similar to GABA. The half-life of Phenibut is 5.3 hours. It's renally cleared. Bioavailability with oral administration is fairly high, 64% inactive metabolites. People can get in trouble initially when starting Phenibut if they're not experienced, because the onset of action is really slow, being 2 to 4 hours, although rectally much quicker, with the peak effect being 4 to 6 hours in. So if an individual is taking this, oh, don't notice effect, taking it again, don't notice effect, really 4 to 6 hours in, they may have taken several doses trying to figure out, when is this going to kick in, and then they really realize they've taken too much. So first-time users may take too much. Again, nasal insufflation is really painful. This is a slide representing poison center data from MMWR, published in 2020, that shows that really we started to see Phenibut in the US in 2015, it peaked in 2018, those started to decline, although I think we will be interesting to see in 2020, 2021, and even into 2022 if we don't see a resurgence of use and interest, in particular with people stuck at home with COVID, and increasing anxiety and increasing use of just sedatives in general. Out of these poison center cases, 6.2% had coma, just about 12% had other life-threatening symptoms, and 10% Phenibut was the only substance, and there was 1 death in this data set. Phenibut is has a combination of GABA B activity like baclofen. At really high doses, it's also a GABA A agonist like a benzodiazepine that tends to be really high. And it also has some effect on the alpha-2 delta subunit of the voltage-dependent calcium channel. It's a little bit of gabapentin-like effect, but not as potent. So you heard Dr. Steck mention maybe adding gabapentin. So, that's, I think, if I don't have the option of phenobarbital, I may consider a combination of baclofen and gabapentin in a patient in a detox setting. This is just a slide showing binding affinity to the different receptors. We have GABA B, which is, you think of baclofen, and baclofen has very high binding affinity. The lower the number, the stronger. Phenibut, much higher than GHB, and we don't see benzodiazepines, not GABA B agonists, but Phenibut does have GABA B activity. And then when you look at the alpha-2 delta subunit of the calcium channel, we've got Phenibut, much stronger than baclofen, although gabapentin is your prototypical agonist, or effects at this channel, as well as with pregabalin. We don't have pregabalin KI here, but so Phenibut is a combination of those two actions, and then high doses GABA A like benzodiazepine. All right, so the protocol for this patient was developed as they're admitted to start with baclofen 10 milligrams 4 times a day, with potential to increase to 20 milligram increments if the patient had withdrawal symptoms that were not mitigated with the baclofen. And then once stable, the titration would occur every 24 hours by 25%. Gabapentin was also started with a higher starting dose, 1,200 milligrams, initially on the first dose with 600 milligrams 4 times a day, with again a 25% decrease 24 hours after the withdrawal symptoms had been attenuated for 24 hours. And then the plan was to add valproic acid when 50% of the starting dose of baclofen and gabapentin had been reached. So the patient was at 5 QAD of baclofen or 300 QAD of the gabapentin. And then there's some adjunctive supportive medications, clonidine, hydroxyzine, and other typical melatonin, ibuprofen, acetaminophen, and other meds available. And the provider contacts her outpatient prescriber to discuss the clonazepam and buprenorphine. Clonazepam is not planned to restart, and buprenorphine depends on the patient decision. The patient initially reports they want to stop everything. And with the plan to stop the clonazepam, diazepam was added only if the C was over 8 and the patient was not having the symptoms controlled with the baclofen and the gabapentin. So any panelists, any thoughts about, and again, phenobarbital would have been the go-to plan had the patient been in the hospital setting, or in a setting we could use it. I would have used the protocol Dr. Carnes mentioned, is my preferred, simplify, shorter, but do you have any thoughts on this regimen? We'll start with Dr. Illig. Good comments from our fellow.
Yeah, no, I mean, at least to me, cursory, it seems like an appropriate regimen. I think one of the questions that kind of came up when I was speaking with Dr. Carpenter earlier about this, and there's been some case reports in patients being treated at home or in an outpatient setting of kind of having a cross taper of their Phenibut with baclofen or something of that nature. So Would just be interested, I guess, to even hear the other panelists maybe speak to the utility or the feasibility of working with a patient in an outpatient setting and kind of slowly tapering down their Phenibut while increasing the baclofen or other adjunctive medications that are being used, or if anybody's had any experience with that, because again, it was mentioned in one or two case reports, and I guess an interesting idea behind it, but not sure if that's something that is done routinely or is even feasibly here in the US.
Yeah, that's a great comment. I've seen those case reports. My experience is tapering with the substance that one individual is dependence and use disorder with is very challenging. So if you have an opportunity to get the individual out of the environment and it's feasible, I usually prefer to do that. Often the tapers are slower. You can use safer medications that may not be as safe in the home setting, like phenobarbital or a combination of sedatives. I would worry that not only do we have Phenibut, now we have gabapentin, baclofen, and then a combination of sedatives. But I have seen that successfully done, and there are reports, just as even Dr. Carpenter discussed. So certainly, if there's no detox sites available, that I think would be a reasonable protocol to try and see if it worked with backup plans. Dr. Carnes, what are your thoughts on this?
Yeah, I think, from a pure, receptor activity, point of view in terms of gabapentin and baclofen hitting those same sites that the Phenibut acts on, I think it makes a lot of sense. I think my concerns are the same that you just brought up, which is, you have a polysubstance abuse and a history of that. And in addition, a history of a seizure that would also sort of tip my hand to not being terribly comfortable with doing this in an outpatient setting, even though we're not sure what caused that seizure. Kratom can cause seizures, so maybe it was related to kratom abuse. But I do think I fortunately am not put in that position too often because I'm in this setting. But I would have similar concerns about giving a lot of gabapentin. I mean, we see a lot of gabapentin abuse and dependence up here. So it's something that, especially with the buprenorphine on board, I would be hesitant to do that.
Great comment. Thank you. Dr. Carpenter, do you have anything additional?
I think this is as elegant a solution as you can do in terms of hitting, GABA A, GABA B, and that alpha 2 delta subunit of calcium channel. So I think it's a pretty elegant solution mechanistically.
Stuck anything you want to add?
No, I mean, my initial reaction was like, ooh, giving back some benzos there. But like Dr. Carpenter was saying, if pharmacologically you need to hit the GABA A as well, I think using something like diazepam, which is going to kind of have that active metabolite and the quote self-taper aspect to it, is a decent option.
And Dr. Bishevitz, we have anything additional in the chat or Q&A that you want to address or comment on?
So there was a question about why would you substitute diazepam, but I think Dr. Steck just answered that. And there's another question about if someone is given clonazepam and buprenorphine for opioid and benzo withdrawal, could they have severe headaches if the medications just stopped?
Well, I would expect low onset of withdrawal, and certainly headaches can be part of withdrawal.
Yeah, it's always hard to evaluate such a non-specific thing.
And this patient had migraines. Go ahead.
There's another question in that someone is raising his hand in the Zoom, and I'm not sure we have the capability for that because we haven't done raised hands before. Do you know?
We do not have the capability of adding audio, so you have to type in the question if you got your hand up. Just type it in the Q&A ideally, so we can come back if someone has a question or comment.
Hopefully the person heard that and will ask.
Yeah, that'd be good. I really welcome the contributions from the attendees. Some great comments and questions. So the patient has a CWA scoring used during I should say his stay, although medication is dosed based on a scheduled protocol with addition of the diazepam. He's scoring 3 to 8 during days 1 to 4 when symptoms improved and the titration of gabapentin and baclofen began. Diazepam was stopped. It was only given twice once the score of 8 was reached. And symptoms were really only mild and subjective during these days. The patient was sleeping, eating, and while reporting tremors, was not noted to have any tremors, seemed to be doing well during medication passes and other assessments. Buprenorphine was started on day 3 with 2 milligrams once and then 4 milligrams twice a day. They had mild opiate withdrawal symptoms that were both different from Phenibut. I know what opiate withdrawal is. Although the symptoms overlapped with the sedative withdrawal scale, SIWA, nausea, some tactile disturbance, anxiety, insomnia, and these were all subjective symptoms. Initially hadn't wanted to start the buprenorphine, but changed their mind fairly quickly, it seemed. No episodes of oversedation, no observed objective signs of withdrawal other than some initial restlessness and anxiety during the days 1 through 3. And he tolerated the medication taper without issue, and valproic acid 500 twice a day was started on day 6. The levetiracetam was started on day 2, only because it had to be ordered in, as was the lorazepam, because it was determined that he was taking this regularly, as well as the seizure medication. Did not require any sumatriptan, and did receive some clonidine and melatonin at night as well. A patient completed a 9-day detox regimen and was continued on the buprenorphine 4 milligrams sublingual twice a day and transferred to an inpatient facility where 1 week after the buprenorphine was increased to 8 milligrams twice a day. And he's remained off the clonazepam and Phenibut. Then while inpatient was planned to discharge to his parents and continue an outpatient treatment program, valproic acid was continued for 4 weeks and then stopped. The patient did not report any symptoms upon discontinuation other than they felt more mood stabilization, though I feel pretty good. I think I'm all right without it. And so it's ongoing, but seems to be doing well. So a little bit about Phenibut withdrawal management. This has really been discussed. I'll just go through it fairly quickly. There's some case reports that describe use of baclofen tapers as well as benzodiazepine tapers. I've got one reference. The amount used was lower in this report, so lower dose Phenibut, fairly quick baclofen and benzodiazepine tapers. And then there was another report that, as Dr. Illigan mentioned and Dr. Carpenter, outpatient Phenibut taper along with baclofen substitution over an 8 to 12 week period. And these authors determined that 1 gram Phenibut substitutes for approximately 8 to 10 milligrams of baclofen and advised on a slow taper. And I've got the reference here. If who's interested, it's in British Medical Journal case reports. And this is basically the summary of the baclofen titration as well as the Phenibut. And this individual is also using Kratom. And if you look at this case report, it's more complicated. There's other substances and a longer history of substance use disorder. And again, you had the opioid, the Kratom, but interesting, an outpatient taper over 12 weeks. So let's, in the interest of time, move on to the second case, unless the individual with their hand raised, that they type in anything. Dr. Bashevitz?
No, they did not.
Okay, so let's move on to case 2. No one there even knew what it was. This is a patient with use of Kratom, alcohol, and sedatives, intermittent benzodiazepines. It was a seizure after a brief relapse with alcohol about a week after leaving detox, where he had been treated for alcohol and sedative dependence. Kratom use was not really addressed during the detox. The patient's urine screen is only positive for ethyl glucuronide in addition to the detox. They are negative for opiates, cocaine, methamphetamines, amphetamine, benzodiazepines, tramadol, fentanyl, oxycodone, THC. Initial CIWA is 7. He has a past medical history of eczema and hypertension, though currently not taking anything for hypertension. And med only brought in hydrocortisone. So 7 cigarettes a day, lives with his mother, has been monitoring his use of Kratom and trying to get him to enter detox. For weeks now, he lost his job and apartment 3 to 4 expired due to use. And withdrawal is limiting his ability to work. The patient had been drinking 24 12-ounce cans of beer. That slide is missing here. And so it really come in for and alcohol detox, not just Kratom. The intermittent sedatives have been in the past. Patient had started on diazepam, 10 milligrams 3 times a day, PRN for C/8, and for 24 hours is doing well, no symptoms, he rests well. Diazepam is dosed 3 times daily, scoring. He has adjunctive clonidine and some hydroxyzine. He declines discussing medications for alcohol use disorder, either naltrexone or camprosate. And Kratom use, although he brought up his use, isn't discussed, at least initially, apparently. And then on day 3 and 4, he has increasing insomnia, and he asks about getting some Suboxone for Kratom withdrawal. He reports symptoms for Kratom withdrawal as anorexia, cramping, anxiety, sweats, and tremors that have now been unrelieved with the diazepam and clonidine. He meets with a provider who notes that the CWAs are low, does a clinical withdrawal scale, and notes only subjective symptoms, and notes indicates that he's sleeping, feels the time frame isn't consistent with Kratom withdrawal, although he really didn't know much about Kratom, had to call another provider to ask what it was and if withdrawal occurred. So panelists, what is your experience with Kratom use and dependence? Have you treated patients with Kratom withdrawal, and what is the timing and duration of withdrawal, and what symptoms occur? And just so you get some background, the patient had reported using Kratom he obtained from a website with quality control, used several times a day, mixing with hot water and lemon juice or tea to get it down. He was using 16 grams to 20 grams a day prior to coming in, although he had tried to cut down preceding detox bag amounts, about amounts and time. He really had presented primarily interest in getting off the alcohol and not returning to alcohol use. And Kratom was mentioned, but not really part of the initial focus. So, Dr. Steck, you want to comment about your experience with Kratom?
Sure. We have right around the block from our outpatient clinic, we have a shop that sells Kratom among some other choice substances. But the patient I always think of when I'm talking about Kratom use is a woman who came to our clinic in 2018, having started her Kratom use in an attempt to, quote, self-detox from her oxycodone use. And so, it worked really well. She wasn't using oxycodone anymore, but then she couldn't get off the Kratom. And she was taking, somewhere on the order of, 80 to 100 milligrams a day. And really kind of had, the classic pharmacology of it. So in the morning, she would take a couple teaspoons with her coffee to get like the, quote, low dose stimulant effects and kind of get herself going. And then throughout the day would gradually increase or escalate her dose, so that by the time she got to the evening, she was feeling the sedative effects from it. And interestingly, I think by the time she had gotten up to doses that were quite so high, if she missed a dose, and she dosed somewhere between every 4 to 6 hours, if she missed a dose, she would start experiencing symptoms within only a few hours. So she wasn't able to even titrate down. So it, in her experience, had very rapid onset of withdrawal symptoms. And as for duration, I'm not sure. I've yet to work with anyone who's been able to stop it long enough to see how long they last if you don't intervene.
Dr. Carnes, you had a lot of experience with Kratom.
Yeah, we see a lot of Kratom, both in the setting of trying people with opiate use disorder, substituting and trying to not use opiates, and using Kratom instead as a kind of a natural alternative, but also people without opiate use disorder who start using Kratom because a friend does, or it's going to help you with your anxiety, or it actually helps sort of me focus, if I take just a little dose. So we've had both people with opiate use disorder and without, and the withdrawal syndrome is pretty impressive, actually, especially with those higher doses, 80 to 100 grams a day is the highest I've seen as well. And it's just as impressive as somebody coming off of fentanyl, in my experience. I'd say the timeline, I think this case, because the patient was getting diazepam and some other comfort medications, that can hold them for a couple days, even. Maybe usually about the time that it would be safe to and start buprenorphine. Actually, get 36 hours out, you can precipitate withdrawal, with buprenorphine when somebody's using kratom regularly. And you certainly can with naltrexone. So it was nice to hear that he had no interest in naltrexone or acamprosate, because that would have been a disaster. But in terms of duration of the withdrawal syndrome, the worst, very similar to opiates, 4 or 5 days, the intense symptoms. But, even after coming off, in the absence of buprenorphine, for maintenance would be pretty significant post-acute withdrawal syndrome too.
Yeah, thank you for that summary. Dr. Carpenter, what's your experience been? Been in a couple different settings, different demographics of drugs, but kratom, were you practiced?
So the majority of my kratom experience is from the same patient that Dr. Steck described. In terms of the questions that are posed here, I do agree with Dr. Carnes that the time course seems a bit long, and perhaps that's because it was blunted by the benzodiazepines this patient was receiving. I would usually expect it to happen on the order of a few hours to maybe a day. And clinically, when I've seen it, it pretty much mimics almost spot on opioid withdrawal. And the majority of the patients that we've cared for have not gone through that full natural course of disease. We've intervened usually by starting buprenorphine somewhere around 24 to 48 hours after their last use.
Yeah, that's good. The only comment I have is I think there's some other components to kratom. We'll get a little bit into that. Buprenorphine is my preference to use. And in this patient, I'd wonder if, do people cheat their medications? Unfortunately, not uncommonly, and I'd wonder if he, hadn't gotten some from another patient, maybe day 2 or something. Hey, and he's getting sick, and that has happened. So I would be curious about that he's asking for buprenorphine. I've seen individuals self-taper from buprenorphine using kratom, and I've seen individuals transition a number of patients from kratom on buprenorphine, and now they're doing quite well. Often history of opiate use disorder prior, use kratom, pain a lot. Some of them have had side effects as if they've had lost their supply, had adulterated kratom, but there's also a strong advocacy group online about the use of kratom for chronic pain, and interesting history about that we're not going to necessarily go into at the end, but it's all over the place, and you need to really be familiar with kratom. Treat the dependence just to be understand what it is, and to be able to have a dialogue with patients. Dr. Bashevitz, is there anything in the chat about questions, comments, or in the Q&A that you want to share?
No, nothing new. And I've seen a bit of kratom here as well. And I've also seen it where people go into kratom and end up spending too much money and get back to street heroin or fentanyl because of cost.
Yeah, no. Yeah, absolutely. People can spend, especially if they're just going through the shops, and it can be very expensive. Dr. Illig, have you had experience with kratom, whether in Detroit or down in Atlanta?
Yeah. So my main experience was, in residency in Detroit. It was fairly popular. We saw it a lot of times in patients with opioid use disorder who desired to abstain from using heroin or other illicit substances. So they would start themselves on kratom and then eventually present to the emergency department because they were having trouble weaning themselves off of the kratom, and they desired to abstain from kratom use as well. So a lot of what we would see is kind of the withdrawal syndrome, like Dr. Carpenter mentioned, mimicking opioid withdrawal. And then really the challenge of linking these people to providers in the community who were familiar with treating people with dependence on kratom and helping them ultimately abstain from it. So saw quite a bit of it in the emergency department, but not so much on the treatment side, more of the kind of referral to care side.
Yeah, no, that's a great comment. It's really important that this not just simply be dismissed in the EDAs you're using a supplement that doesn't make sense. You're having these symptoms. There's some other symptoms, certainly whether the kratom has the product is adulterated. We've at U of R seen an individual have a stroke after kratom supply was late, and an individual, a significant other, purchased kratom from a smoke shop and had very odd symptoms, including a marked stimulant effect initially, and one of the individuals had a hemorrhagic stroke. It turned out the kratom had been adulterated with phenethylamine. Historically, individuals have adulterated some of the products with desmethyltramadol, the potent metabolite of tramadol, which resulted in a number of overdose deaths in, I believe, Ireland years ago. But this is, caveat buyer beware. It could contain other things, including extract, the methadronine extracts of concentrates instead of just the natural plants. So a lot of caveats. This is a little bit about kratom. It's a common name for the tropical tree plant native to parts of Southeast Asia and Africa. Mitragina speciosa is the name indigenous to Thailand, Indonesia, Malaysia, Myanmar, and Papua New Guinea. Users typically chew the leaves for the stimulants and then the analgesic effects at higher doses, or taken. You can see capsules that's sold. Now the smoke shops are usually in capsules, ground powder, or usually ground pulverized leaves, and tend to be different products available, mostly really via advertisements. Got a blog post that details review of kratom as well as a case report if anyone's interested. That's referencing myself. The pharmacology is, I think, still there's a lot to it that hasn't been quite elucidated. It is a stimulant at low doses has been mentioned, and at higher doses more anxiolytic and analgesic effects. It is a complex activity. It's active at the mu opioid receptor as well as the delta opioid receptor, and has effects on serotonin and mixed effects at the alpha 2 receptor. Although in looking at more recent literature, including methadronine, one of the active alkaloids, has a more complex pharmacology at the mu receptor and what it does downstream. So it's still being elucidated. In general, though, it does, my experience, appear as an opioid withdrawal toxidrome, along with maybe some other discontinuation syndromes. So usually some serotonergic, so maybe some additional effects that you need to balance out beyond just simply the opioid withdrawal. So the patient is discharged to home on day 5, and he declines follow-up in an outpatient facility. He really underwent alcohol detox with clonidine. He has a job interview he's excited about and feels he wouldn't have time to attend an outpatient program. Immediately on returning home, he resumes use of kratom. He says they didn't give me anything for it. His mother is keeping it and giving it to him at defined intervals. She is very worried about this. He doesn't appear to start drinking, though. 5 days after he's discharged, though, he relapses with alcohol per his report after having several shots after an unsuccessful job interview. And about 2 hours after this, he has a generalized tonic-clonic seizure witnessed by his mother. She calls 911. The EMS brings him into the ED, where he's found to have a fracture of his distal left radius and some other bones, as well as a proximal ulna, non-displaced, and the Toxicology Addiction Services consulted for withdrawal management. Patient is mildly tachycardic on arrival, though this improves after a dose of Clonazepam and fluids. He reports having eaten very little since detox, having minimal sleep and stress. He says he's been using about half the amount of kratom he used before and felt stress, insomnia, anxiety, and kratom withdrawal. He says that may have caused a seizure. He denies use of other substances except the alcohol. His alcohol level in the emergency department is 92 milligrams per deciliter, about 4 hours after his last drink. So my question to the panelists is, what are your thoughts about the symptoms, time course, onset of seizures? Has seizures been reported with kratom withdrawal? Are there other questions you would want to ask the patients? And I'll start with Dr. Carpenter.
I have so many questions for this gentleman. A lot of the problem with when we talk about kratom and seizures is that since this is not controlled, it just hasn't ever been studied in an appropriately controlled manner, in a prospective manner. So what we have is limited to case reports and small case series. Have I seen associations of kratom and seizures? Yes, mainly more in use than in withdrawal. And my problem with that data is it's primarily poison center data. We don't often have objective laboratory confirmation that there wasn't a co-ingestion of a stimulant or other pro-epileptic. I've also seen some reports of seizures associated with long-term high-dose kratom use. Interestingly, when you look at those reports, there often is CNS imaging that shows a structural abnormality. And then we're left with this question of chicken and egg. Did the patient have the structural abnormality first that made them a setup to have a seizure, or did the kratom cause this? We simply just don't know because there's no controlled data. What I would like to know from this gentleman, of course, he's buying this off the internet. What could be in it? You've already talked about some of the other adulterations we've seen over time. I'd like to know, yes, he took these shots after a bad job interview, but was he feeling withdrawal symptoms otherwise beforehand? He had a pretty heavy history of alcohol use. And though we often think of diazepam as self-tapering, there are some patients that might need a longer taper. So I'm not sure what he got after he was discharged from that inpatient facility, if anything. But did he need some form of longer benzodiazepine taper after he left? I'm not quite sure.
Yeah, those are great questions. He was not continued on a benzodiazepine taper. It seemed his scores, the CIWA scores, were low, although he self-reported not sleeping and not eating well, and then reporting that continued as he tried to use less kratom. And really, that was somewhat influenced by his mother. I think she expected him to come off the kratom and have something for that. He was not given anything. Well, he declined other medications for alcohol use disorder, and then again, the kratom dependence was not addressed with buprenorphine or anything. It's not clear exactly the detail, how much detailed discussion, or if you really, pushed or asked, more than the initial him having kratom withdrawal into 2, 3, or 3, 4, and he did have a relatively short detox course. I believe it was like 5 days, and then he left. So his urine screen was a basic screen in the ED and showed benzodiazepines and no stimulants, but the stimulants would just have been amphetamines or cocaine, and we had an alcohol level of sorts that he had been drinking, and we did not have the kratom to test. And here you say kratom, I say kratom. I'm interested in what Dr. Boyer says, but I heard I may be mispronouncing potato. Dr. Steck, do you have any other thoughts or comments on this? The onset of seizures and symptoms at this point?
Yeah, I love everything that Joe brought up. And I think those are all perfect points. The only thing to throw out there, which I think you had alluded to earlier, is this intentionally, I don't even know if you'd call it adulterated, this intentionally created mixture of O-desmethyltramadol and kratom or kratom. How I think I tend to pronounce it kratom. And that goes by the name Krypton, which I just love. It's quite clever. But I wonder if maybe he was obtaining his kratom from a new source, if he had intentionally or unintentionally stumbled across this formulation, and if that could have contributed to his seizure. But really, that's the only other thing I have to add.
Yeah, that's right. Supposedly, this is the exact same product that he'd been getting all along. It wasn't that he'd ran out; that still had some at home. Dr. Illig, any other comments?
No, I really don't have too much to add in addition to what Dr. Steck and Dr. Carpenter said. I guess the only other question I would have is, in his efforts to cut back or quit using alcohol altogether, is he using kratom in greater quantities than he prior had? And could there be some direct effect from a higher dosing of kratom that potentially led to a seizure? But nothing else to add.
That's a good question. And no, he said he'd been using actually less. So he's adamant about only relapsing the one day, denies use of benzodiazepines. He says the kratom is the same he's been using for the past 7 months in terms of the product. His mother doles it out. He was guarded with information until she's asked to leave. The bedside exam will provide the same information, get a little bit more relaxed. He's relieved the provider is familiar with kratom. He says His last use was about 10 hours ago now, normally 5 to 6 times a day. I'm going to just jump ahead. We've kind of talked about Rex and plans, at least in other panelists' experience. The plan for him was to start a buprenorphine dose of 2 milligrams once, along with 0.1 clonidine, and his symptoms improved quite a bit. We added valproic acid, 500 milligrams twice a day for subacute withdrawal, post-sedative and alcohol use, and he has some orthopedic surgery involvement. And he's linked to an outpatient program for follow-up on 2 milligrams twice a day, or excuse me, 3 times a day. And it's 3 times a day really for pain. He has some fractures, and he's gets the injury from his seizure, and with the valproic acid. Telemedicine follow-up is done 3 days after his hospital discharge, and an observed dose is done via telemedicine. He reports he's had some cravings, but otherwise, thank God, and the other med is helping too, and he says that's valproic acid. He's prescribed at that visit 4/1 milligrams twice a day, and an on-site visit is scheduled for 5 days later on a Friday. This is a Monday, the telemedicine visit. A patient is seen on site 5 days after the telemedicine visit, and he reports doing well, no use of alcohol or other drugs. His mother got rid of the Kratom, and he's had a lot of other appointments, but he's doing well. He notes good sleep and mood stabilization in the valproic acid. We'd like to continue with it. The 4/1 milligram twice a day is increased to 12/3 daily after he reports mild cravings, but no withdrawal. His pain is okay with also acetaminophen or ibuprofen. He remains engaged with the program, meets with a counselor weekly, has a scheduled mental health assessment 1 to 2 weeks from this appointment. He's very pleased with the medication. And during this on-site visit, he gets into more history as he sees some book on the shelf, T-Call or P-Call or something. So he relaxes about his history of use, and he describes extensive experimentation with hallucinogens for years, and then primarily opioid use until substituting Kratom for heroin about 7 months prior. About 6 months after he had detoxified from heroin and using buprenorphine in an inpatient program, but he didn't feel right. He did not continue on medication for opioid use disorder during that period, and then started drinking, using benzodiazepines, and then he picked up the Kratom for about 7 months, and then that had led into this request to detox. So very, very briefly, any other final thoughts on this case? Would you have treated differently? We covered valproic acid a little bit, and I have a really nice reference from our colleague Stephanie Weiss, who's done a systematic review of literature on treating Kratom withdrawal dependence with buprenorphine. As I recommend anyone interested, it's in the Journal of Addiction Medicine. But, any final thoughts, comments?
The only thing I'd add is I was curious about how much he was using benzodiazepines, before he came in as well. He said he sort of used them intermittently. I'd get a little more history on that, because that could certainly explain an increased seizure propensity, that could have been brought on by the sleep deprivation and increased anxiety, all those things. I don't think the withdrawal from Kratom, or at least I don't know of anything that suggests that Kratom withdrawal causes seizures, but certainly those are stressors, and withdrawal could be a stressor for somebody who's already prone and predisposed to that. So that would have maybe affected how I managed him in the first go around. Would be.
He downplayed the benzodiazepine use when he was in the detox, and it was not positive for benzodiazepines initially. Although, and it was not clonazepam that he'd been using, although a mixture of different benzodiazepines. It's possible that he could have had some designer benzos that was triggered. Any other thoughts, Dr. Bishevitz? Any final chat comments?
I have a thought on the valproic acid. I think many people do benefit from it in withdrawal, but I just wanted to mention that it's not a benign medication. There are a lot of side effects with it, especially weight gain. You can even get tremor from it, other side effects, and especially in withdrawal, if the person has opioid use disorder and needs methadone or is already on methadone, there's an interaction between Depakote and methadone. It's something that we try to avoid using in methadone maintenance.
So that's a great comment. Usually the protocol that I'm using is 2 to 4 weeks, and then reassessment. But adjunctive, it's somewhat similar to what ASAM guidelines are recommending for benzodiazepine sparing protocols with valproic acid or carbamazepine. But yeah, those are great points. generally not going to be a chronic medication for the patients, but just for the kind of protracted subacute symptoms. So good thoughts.
And there's-
Any final comments, Secretary Lake? Oh, go ahead.
There's a couple of other
Gloria?
things in the chat here. Has there been significant use of kratom with street fentanyl? I imagine there probably has. Fentanyl seems to be used with everything, but I haven't seen that many specific cases of it. Anybody else see this?
Well, I certainly see people using kratom to stop. They're using fentanyl and many other opioids. I've not seen any adulterated kratom with fentanyl, for sale. I'm sure that individuals are using, one or the other. And I've known individuals that have not been able to get access to their typical opioid, go to the smoke shop and buy some kratom because they're in withdrawal and couldn't find buprenorphine or other opioids. So I know that is, another use, just single use as an opioid replacement. But
The other
comment.
The other chat question is, could we address the component of serotonergic withdrawal from kratom cessation?
So that is a good comment. And I have, in a couple of patients, used venlafaxine for a period of time, and then in some, while they're waiting to get the evaluation for mental health, continued it. And in at least one of the patients, they'd been on it previously and had good effects, so it was continued. And that seemed to help with some of the symptoms, and we didn't need to titrate up the buprenorphine. I found that usually patients stabilize on lower doses initially, but on the follow-up visit, they have some craving, so the dose gets bumped up. And then on the second or third visit, they still feel good, but there's still some craving. And so typically, I end up with general, normal opioid use disorder doses with like 16 milligrams, as a common dose, whereas the withdrawal was attenuated at a lower dose, but I still, didn't quite settle out until higher. But I have used adjunctive venlafaxine, clonidine early on common, and then, there's, in this patient, he had the alcohol instead of valprogatin. Was not for the kratom itself, it was because of, concern for alcohol and sedatives, and he had the seizure. So we are essentially at the end of our time, unless there's any other burning thoughts. I really appreciate the panelists' comments and everyone joining today. Some excellent comments from the audience. And we end with the final thoughts. This is from the issue of The Sun, which is a literary journal magazine published out of Chapel Hill, North Carolina. And it's a poem, "A Few Days After My First Vaccine," by Allison Luderman, published October, issue 550. "Walking by the lake, I lose an earring and don't even notice it at first, overwhelmed as I am by the strangeness of everything. Blocks later, my hand reaches up to feel that slight absence in one ear. Then I have to retrace my steps, as they say to do, past the guy jogging with his mask pulled down, and the hijab-wearing, stroller-pushing young mother in stylish jeans, and the homeless man emerging from his tent on the banks of our urban oasis, bearing a boombox on one shoulder. And that's where I spot it, lying on the sidewalk, miraculously untrampled, small, precious, found thing, a turquoise oval encircled with rows of beads, given to me with love by someone I haven't hugged in more than a year. Tiny rescue from the sea of loss, just as we seem to have found a raft to grab onto in the wake of a shipwreck so vast we cannot yet imagine the end of it." So thank you. This is a little bit busy slide, but mark your calendars for the next addiction toxicology case conference, Friday at 1 p.m. on the first Friday of November. We've already got some guest panelists. We're going to be talking about harm reduction strategies related to alcohol use and some ethical issues in addiction medicine. And as always, feedback is of interest and well received, so please send feedback, comments, interest, ideas for topics. And again, a reminder, the ACMT abstract submission is open until November 15th, and today is the deadline for the final ASAM abstract. So if you have some abstracts or interest, get those in. And you can check both the ACMT and the ASAM websites for past recorded sessions and FAQs. So thank you all for joining me. And again, thank you, panelists, and everyone have a great weekend. We'll end today. Thank you.